Frailty is a state of vulnerability. It helps us understand why some older people with more advanced frailty are vulnerable to deteriorations in their function, for example, developing confusional states or immobility in the face of a relatively innocuous insult. So an illness that might lead to you or I perhaps being a bit under the weather for a few days and perhaps having a day or two off work. That same illness, a viral illness of some description perhaps, could lead to a much more serious impact in an older person with frailty. We measure frailty in clinical settings using something called the Clinical Frailty Scale, and that's widely used in acute hospital settings, certainly in the UK, which is a quick, simple and easy to use scale that helps us to identify the level of frailty in a given individual. But it does come with an implementation burden. We have to teach people how to use it. We have to check that they're using it accurately. We have to record it on our electronic systems if we want to track people through. So there is an implementation burden associated with it. And even in the very highest performing systems, you rarely get completion rates beyond, say, 70%, which led us then into this work on the Hospital Frailty Risk Score, which takes diagnostic codes, so-called International Classification of Diagnosis codes, which are available on discharge records and when patients go home, and we're able to derive a frailty risk score using those codes, which then allows us to capture frailty in all patients discharged from hospital, the whole system through the lens of frailty.
So clinicians and researchers around the world have been using the Hospital Frailty Risk Score to assess the frailty of their own patients. So older patients admitted to hospital, or patients admitted to intensive care units, or patients admitted to hospital for cardiac procedures. And studies have been conducted in countries such as Australia, Japan, Sweden, Germany, Switzerland, Canada, and the United States. However, what we've seen in the published literature that has used the Hospital Frailty Risk Score is that there is some inconsistency in how it is being calculated. In particular, in how the diagnostic information from the patient's medical record is used in the construction of the score. So what we wanted to do in this study is provide some definitive guidance on how much diagnostic information from past admissions for the same patient should be used in constructing the frailty risk score. What we did in this paper was to look at the diagnostic information for a group of patients for both their current admissions to hospital and then a succession of historic admissions over the previous years for the same patients. So to do this, we analysed data for all patients over 75 that had been admitted to hospitals in the Yorkshire and Humber region over a 7-year period. Having analysed the data for those patients, we worked out how much information needed to be used to construct the Hospital Frailty Risk Score in order for the score to act as a good predictor of how long patients stay in hospital, their probability of dying in hospital, and their probability of being readmitted to hospital as an emergency some 30 days after their discharge. What we found when we undertook the analysis was that to construct the frailty risk score, it's sufficient to take account of diagnostic information from the current hospital admission and the 2 previous hospital admissions for the same patient if they occurred within 2 years of the current admission. When the Hospital Frailty Risk Score is constructed in this way, we find that it's a very good predictor of how long patients stay in hospital. It actually predicts long length of stay in hospital better than any other characteristic of the patients that we have data about in their medical record.
The good thing about having the Hospital Frailty Risk Score is it can help us at 3 different levels. So at the micro level, the individual patient level, it should be possible to generate hospital frailty risk scores and attach those to an electronic patient record, which would then obviate the need for the clinicians to do frailty scores, although you always need to recheck the information to some extent. At that service level, the so-called meso level, the frailty risk score can be used to evaluate services. So, for example, if you're setting up a frailty service in your acute medical unit or your emergency department, you'll want to know the impact of that service on patient outcomes, such as length of stay or readmissions or mortality. Perhaps the most exciting opportunity with HFRS is to think about it at the whole system level, because it then allows us to create frailty registries, and we may perhaps even think about combining the HFRS with something like the Electronic Frailty Index, so that we can map frailty across the whole system and look at frailty-related outcomes in both acute care and in primary care. And excitingly, it lends itself to the opportunity to attach more patient-centered outcomes. So, for example, patient-reported outcome measures, maybe function or quality of life or well-being. And that could inform clinical care both at the individual patient level, the service level, and at the system level, helping us deliver much better patient-centered care.